left ventricle?
Nothing but the left ventricle. Everything is going towards V6, right? Or completely biphasic when we look at some of the posterior. But because it's rounding that corner, it does see some of that posterior already. So when we look at V6, it's just a big positive wave. Does that make sense? So we are talking normal, a normal person with normal physiology and no problems. If I look at somebody with normal physiology, with an anatomical heart that's appropriate, that's been developed correctly, and I place my leads properly, this is what I should see on my V leads. I should see V1 being the most negative, V2 being very negative, but maybe not as big as V1, V3 having a lot of positive and a lot of negative, but likely still a little bit more negative than positive, V4 being slightly more positive than negative, my transition being somewhere between V3 and V4, V5 being very positive, and V6 being the most positive. That's what we mean by a z-axis. That's what the z-axis should be. Does that make sense? Questions on that? Everybody solid there for a moment. On what you should see there. Yes.
So are all of those on the same plane?
All of them are on the
Even
transverse plane.
Even yeah, but you're placing one in the fourth intercostal and then one in the fifth intercostal
Yes.
space.
So the
Are the
plane,
electrical activities still compensated so that it's the same level within the heart?
no. No, because we're catching, the left ventricle is not as much muscle mass up here as it is down here. So as we start going, we're here for V1 and V2, here for V3 and V4, and here. So
you're following muscle mass.
You're following muscle mass.
Got it.
That's right. So we are on the transverse plane for all of them,
Right.
but at different levels of the sagittal plane.
Got it.
Kind of back to anatomical placement. Why for V3 and V5, it's just states put in between. It doesn't really say like intercostal space and all the bits.
No, we do say intercostal. So V5 should be in the fifth intercostal space.
Okay.
So 4, 5, and 6, 7, 8, and 9 are all in the fifth intercostal space.
Okay.
1 and 2 are in the fourth intercostal space. We have no choice with V3. It's a funky lead because it's gonna have to deal with bone because we have a rib there.
Because it says to put it in
right?
between.
But what we want for landmark purposes, V4 and V6 have very specific landmarks, and we want V5 to split the difference between 4 and 6 in that same plane.
Okay.
And we want V3 to split the difference between 2 and 4 within that same plane, so it's equidistant amongst them. But we've got clear landmarks for 4 and 6, which is why we do those first.
Yeah, I totally get that. I just didn't really understand 3 and 5.
And Chris likes to do 4, 6, and then come back and do 5 and 3. Perfectly fine. I do 4 and then 3, and then 6 and then 5. It doesn't really matter. But 4 before 3 and 6 before 5, no matter what, right? Because then you've got the everything split correctly and make it equidistant. Because what we haven't really talked about yet, the hexaxial system, when you do axis, are on what degree separations?
30.
30 degree separations. The z-axis is on 20 degree separation increments. That 20 degree separation would not work if V5 was not splitting the difference between 4 and 6, and if 3 was not splitting the difference between 2 and 4.
Okay.
Does that make sense?
Yes.
Good? Everybody clear on what that axis should look like? Let me finish up a couple things, and I'll give you a break, and then we're going to look at a couple of very specific ones. Okay, so what else are we looking at on 12 lead? What's probably the next biggest thing that you've been
Estilation.
Yeah, you're looking at the ST segment, right? Right? You're looking at ST segment, and there's another big, huge thing that we've looked at as well.
T-wave morphology. T-wave.
ST segment and T wave. There's another big and giant section of which we had that 12 lead to determine.
Bundle branch box?
Bundle branch box.
Oh, yeah.
Okay, so now let me put this all into, let me take all of this and apply it to a bigger picture, right? Of how I think you should look at a 12 lead. So number one, when you're looking at a 12 lead. I'm making this up. I'm making up the term, what I'm saying here. So I think you should take a 50-yard approach. A 50-yard look. You look at the 12 lead from a distance. You just pick it up and look at it and see what comes out at you. In that 50-yard look, I'm specifically looking at two general things. I'm looking at what pops out at me. And the two things that I look at to see what's going to pop out at me is AVR and the z-axis. When I pick up a 12 lead, those are the first two things that pop out at me. Because if AVR is positive, absolutely something's wrong. Because AVR should be negative when?
All the time.
All the time. In every normal and almost all abnormal people, AVR should be negative because the electrical current should always be going away from AVR. So I look at AVR and I look at the z-axis. Because what should the z-axis be? That. So if I pop it up and the first thing that I notice is that V1 is positive, something's wrong. Because there's no circumstances, under normal circumstances, there's no reason why V1 should ever be positive. So something's wrong if V1 is positive, and something wrong is if AVR is positive. So I look at those two because those are easy to pick out, they should be negative. Meaning when I look at my 12 lead, I should see lead 1 should be positive, so I should see blop, 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 bloop, 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 yeah? And if I see blop, 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 there's a problem. And in fact, what I really should see is blop, 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 bloop, 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 blop, blop, blop. Right?
What?
I should see this, I
Can we
should,
say that on a test?
you can. I should see this. And if I don't see that in my top line on my 12 lead, something's wrong. So I key in with my 50-yard look. I'm not going to analyze why right now, but I immediately know something's wrong if I do that. The next thing that I do is I enter that. I go into this stuff right here. So I eliminate the crap, and I go into my 3 rhythm and rate, 4 my intervals, all of that stuff that I just listed under intervals, 5 my rhythm interpretation. Yes? Okay, now things are a little funky, okay? My identification of my crap I may or may not do right now, because now I need to look at some other things. And that crap might be defined amongst other things that I'm looking at. So, after I get done with this, I'm looking at my axis. What's my axis? I might not care about the actual degree of the axis right now, but I am going to note the quadrant, which means I'm looking at AVF, lead 1, and lead 2 as necessary. When do I look at lead 2?
When
When it's what?
when
So when do I look at lead 2?
when
If it's a left axis deviation. But I'm catching where it is in terms of directional flow of stuff. Okay?
Sorry, lead 2 would be more positive. If
Lead 2 would be negative.
If ABS is negative, you can be in LED, then you can look at lead 2.
okay,
If I'm in that quadrant, I have to know if I'm on that line or not,
Yep,
right? Which is -30.
yep.
Lead 2 at -60 is biphasic at -30. So it's positive here and it's negative there.
Okay, so if lead 2 is negative,
Then I've got
That's
pathologic.
bad.
Yep,
Should be
that's right. Right?
yep.
So I'm establishing my quadrant. I'm not necessarily looking at the degrees right now, but I'm establishing my quadrant. And how fast does it require, how quickly can you establish the quadrant?
Quick.
Yeah, you should be able to do that with the snap of a finger. Because you're looking at 2 leads, boom, got it. Right? Okay. After I start looking at that, now I want to start looking at things. I'm going to look at bundle branches to establish a bundle branch block. I'm going to look at anomalies. So my crap, all my crap that I have there, and I'm going to look at mimics. We haven't discussed mimics yet, it's okay. I'm going to look at things that cause ST elevation that are not MIs. For example, I'm going to take, if I see ST elevation, I want to take a look at, is it pericarditis? I want to look at, is it respiratory based? I want to start looking at things that would cause ST elevation that are not related to MIs. What's the biggest thing you've learned right now so far that causes ST elevation normally, but is not an MI, or you can't tell if it's an MI? A left bundle branch block. If I see a left bundle branch block, I know that I'm going to have ST elevation because that's normal in a left bundle branch block. Okay, so I'm going to look at the things that cause ST elevation but aren't MI. And then lastly, I'll identify STEMIs. Once I've ruled out that I've got mimics for my ST elevation, then I know that the ST elevation I do have is related to a STEMI. Does that make sense? So this is my approach to a whole 12 lead when I first look at a 12 lead. I pick it up, I do my 50-yard look. I don't only look at AVR and Z-axis. I'm getting a... You guys understand your general impression? What a general impression is? Right? By now, right? You walk in the room and you immediately have a gut feeling, right? But that gut feeling that you have in a general impression is based on objective and empirical data. Age, sex, skin tone, right? How they're portraying in terms of pain, what they're looking at in terms of what you think the MOI or NOI happens to be. All of that is objective information, but the general impression is objective or subjective? It's subjective. You are subjectively saying this is good or this is bad, right? You're subjectively saying stable or unstable based on the information that just came into your brain, right? That's what this is too. So I've given you 2 pieces of objective data, but there's more, right? Like I'll take a look on that 50-yard look and go, okay, I've got ST elevation going on too. I'm not going to do anything with it. I'm not going to look at that. I just happen to have noted it, right? So I take that 50-yard look, and basically what I'm saying here is you get a general impression of your 12 lead. Once you have a general impression of your 12 lead, then you have to do the assessment. The actual, I'm going to dig in and find out what this means to me, right? And if I look at a 12 lead, and from a distance I go, there's no ST elevation, my AVR is negative, my Z-axis is appropriate, does that mean the patient doesn't have a problem? No, but it means my 12 lead is generally speaking going in the right direction, which is good. You had a question?
No, I was stricken.
You had a question?
I did not.
Yes, you did.
No, I didn't.
Okay, so then I go into my normal rhythm analysis. The other thing you guys have to get used to very, very quickly is remembering that the x-axis in an EKG is what? Time. So you have to get to the point, most pre-hospital monitors don't give you the bottom single lead all the way across. Because the paper is small. The paper is small. paper's tiny. So getting a whole nother lead down there is difficult to do. So you guys have to get used to being able to look from left to right, from left to right, and going, as I go across here, this and this, there's no time in between them. It just goes straight across. And I don't like the soles because of this. I'd rather the 12 lead be clear across, all the way across, without a break, without this little break in between. But you have to remember that the end of that segment right there, the end of that squiggle, is the start of that squiggle. So time going straight across is normal, which means there's no reason why I can't look from left to right on a 12 lead, even though it changes leads as I go, but it still goes straight across, which means I still can identify intervals and I can still identify everything as it's going across. I just need to mentally understand that as I go from one lead to the next, my morphology is going to shift. Okay?
I did have a question.
See? Go ahead.
What are your stop and fix points in that? Like, you know how you do assessments, like massive hemorrhage, A, B, C, massive hemorrhage, you know?
Yep.
What's your,
Yeah, so if you see like STLation, immediately get an intro and ask.
Stop your assessment, do something.
So in here, there isn't exactly a stop and fix. It's a gathering of information that should take you a very short amount of time. So you consider all of this together as kind of your first part of a primary assessment, right? Where you're not really stopping and fixing anything because you have to have all of this information to know what it is that you have to stop and fix.
so you wouldn't add, like, take out rape from your section 2, put it in your 50-yard look, and then go like, this is a rate issue, and then jump into your ACLS algorithm?
No, because I can't just stop at a rate issue because is it an irregular rate issue? Is it a wide complex rate issue? Or is it a narrow complex rate
Or
issue?
is the rate
Am I giving amiodarone, am I giving adenosine, or am I giving a calcium channel blocker?
This just seems real slow. Is that just because I'm bad at it right now?
Yes.
Okay.
This should not take you much time, right? This 50-yard look I've done as I'm coming down to identify everything else. The crap I just mentally get rid of automatically, right? My rate and rhythm is a fast check that I'm doing,
Right.
right off the bat. I notice my P waves, my PR interval, my QRS is all together, right? I'm asking you to do it step by step because you're learning. But you will start doing these things in a very fast combined fashion as you go along, right? A number of these steps are not, so all of these, that's why I put this as intervals, right? Because you're gonna collect all of that stuff right off the bat together. This make sense so far? So that would be your entire approach to a full EKG, right? And then from this information, you might be going, I need a 15 lead. I need to get a posterior look at their heart too. Or I need to get a right 12 lead, because I need the right side right now. So you might extend this based on this information to get more data. That's a possibility too. But this is the place you start, and this is what you're looking at. Good? Questions? Take 5 minutes, go to the bathroom if you need to, and get your EKG books out.
Get that. Oh, sorry. Excuse me. Sorry.